And now it's time to move forward with today's clinical topic. And Randy, I think this is your 17th appearance on
Wow.
this webinar series. There's nobody that's even close. We're just excited to have you here. And for those of you that don't know Dr. Resnik, he is the director of the Resnik Implant Institute, which is without any question the premier implant training program in our country. He's the author of Mrs. Contemporary Implant Dentistry, 4th edition. He's the author of Avoiding Complications in Implant Dentistry. He writes incredibly informative articles for Chairside Magazine. And I'm just excited to bring him back. We always get a lot of questions about occlusion. So Nicole and Dr. Resnik have cooked up a 5-part series on implant occlusion. So let's get started. It's all yours, Randy.
Great. Thank you very much. And thank you for having me back. Uh, Today, we're going to talk about occlusion. And, if you look at the topic of occlusion, this is something that a lot of people are uncomfortable talking about because there's a lot of unknowns. So what Nicole and I and Dr. Park have put together is a 5-part series that today I'm going to lay the foundation. So I'm going to give you some basic concepts on implant occlusion, and I'm going to introduce you to some principles that we'll use throughout the other parts of our lecture series. So there'll be 4 more parts. We'll go through all different types of prostheses, differentiate the ideal occlusion, and give you some principles that you can take back to your practice and implement. Now, if we look at occlusion studies or literature, I've written 3 textbook chapters on it now. I probably have at least 20 articles on occlusion. And one thing I can tell you, I've read almost every article out there in the dental literature. And I have to say, there is basically no general consensus on anything. A lot of the principles are based on natural teeth, which they should be. However, there is a component of the implant that has to be taken in consideration. And that's why if we look at complications and prosthetic complications, a lot of them have to do with the occlusion. And I think if you understand these principles, it's going to help you and minimize those complications. So I have a lot to go through today, so I'm going to get right into it. First of all, there's a lot of controversies in dental implant occlusion. And I'm going to go through just some of the main ones right now, just so you understand what we're looking at when we talk about a topic such as occlusion and how we can actually implement this into private practice. So if we look at the available literature, there are a lot of studies, animal studies, human studies, that show a direct relationship to occlusal problems and bone loss. Basically, if your occlusion is incorrect, you're going to end up with bone loss. A lot of studies out there that show that. There's also a lot of studies that show no direct relationship, both animal and human studies. So there's a lot of in vivo studies that basically are conflicting. Now, why is that? Why with this subject is this so complex, and why is it always so questionable? So I hate to do this, but let me just explain just for a minute or two scientific research and how this works. If we look at this pyramid is called the literature credibility pyramid, and this is based on credible scientific evidence. As we go from the top to the bottom, the quality of information is better, meaning the top, the apex of that pyramid is what we want to use to make our protocols and make our decisions. However, a lot of decisions are made at the bottom on people's opinions that aren't really based on science. So if we look at the 5 classes of scientific research: opinions, case reports, clinical studies, systemic review, and meta-analysis, as we get closer to that apex of systemic review and meta-analysis, those are the studies that we use in science to come up with a conclusion, what we call statistically significant. So with that being said, if we go back to what I said about all these articles on occlusion, A lot of them are expert opinions, just what people think, or maybe what they have developed over the years, or possibly a case study. So when we look at this, this is not what we want to base our principles on. Why? Because people's opinions can be biased. In case reports, yeah, I can show you the nicest implant case that I just put in yesterday. However, does that do you any good? It doesn't. We want to see 5 years out, 10 years out, 15 years out. We want to see what the impact of time will be on these cases. So just by giving a case report and show, hey, listen, this is what I did, that's not always ideal. So what do we want? We want clinical studies. That's what anything in medicine is based on, clinical studies. And there's three different types: randomized trials, cohort studies, and case controls. Basically, they're all controlled. And that is what we want to see. So let me push it one step further. We want controlled studies, and basically these are called cohort studies or observational studies where we look at a particular question over a period of time. There's two different types. Prospective, which means we're looking into the future, where we design a study, and from now until X period of time, we're going to evaluate that patient and evaluate that question. Or retrospectively, we can look in the past. However, when we talk about occlusion, we can't usually go in the past because everything changes, and we don't have the actual records to say that when on this case, when it was put in 10 years ago, it was a mutually protected occlusion. We can't say that. So prospective, ideally, is the ideal study to have. And then you go one step further. You get all these prospective studies, and then someone looks at these in what is called a systemic review. And systemic reviews and meta-analysis are, like I said, at the apex of the triangle or the pyramid. So when we look at systemic reviews, what that author does is they take all the studies on that subject. Say, for instance, should you splint implants for multiple implants? They'll take all those studies and they'll evaluate it and they'll summarize it. Then they'll put it through a statistical analysis, which is called meta-analysis. And then they'll come up with a formula or a conclusion. And that's what we want. So unfortunately, in implant dentistry, we would like to have meta-analysis, systemic reviews for occlusion, but we really don't. They don't exist. There are experimental control groups and some pseudo-prospective in vivo studies, but the problem that we have is the design of these. Yes, we can go to the laboratory and do in vitro studies and see where the force is, see where that's concentrated, and kind of theorize this is what's going to happen if you put the occlusal contact here or if the biting force is here. But that's in a lab setting. And anyone knows that if you look at humans, a lab study or an animal study does not always correlate with what occurs in humans. So a lot of times that doesn't work. And as for in vivo studies, to do studies on humans, we really can't do that because we can't say, okay, Mr. Smith, on your right side, we're going to put these crowns in and we're going to put them in hyperocclusion. And on the left side, we're going to put them into ideal occlusion. And we just want to see what will happen. That's unethical. So that's why there really aren't any in vivo studies, because it's a difficult subject to actually study. So with that being said, sorry to go through that, but I think it's very important that you have to understand when someone gives you an answer, should you splint multiple implants? And they say yes or no. It's really not based on science because there aren't the studies there to really give you that. You can give an opinion, but that's not always the case. And I'll kind of sum that up at the very end. So let's look at the beginnings of implants. Dr. Brandemark, basically the father of implantology, And if you look at his work in the 1960s, 1970s, and then when he started documenting all this and publishing it in the 1980s, what was his final thought on occlusion? If you overload the occlusion, if you put too much stress on those implants, you're going to get bone loss. That's why he came up with the theory of delayed healing. You put the implant in, you let it heal, then you incrementally put force on it. And that was the basis of his research. But remember, what was Dr. Brandmark? What type of doctor was he? He was an orthopedic surgeon. So in orthopedic surgery, that made a lot of sense to him. So that is why a lot of this has changed over time, but that is what we based a lot of the early occlusion on. If we look at some of the historic, and I call them pioneering studies, because these are the pioneering studies that basically back in the 90s set the way for how we developed the occlusal principles. Isidore, in a monkey study, basically what he did is he placed implants in monkeys. On the right side, he put the implants in hyperocclusion, and on the left side, he put a ligature on the implants. And basically, with no occlusal load, he induced a peri-implant disease. So he wanted to cause a peri-implantitis. So what were the results on his multiple studies? Found out that the hyperocclusion side, 62% of those implants failed. Whereas on the other side, with the ligature-induced peri-implantitis, 0%. So the bottom line is his conclusion was occlusal stress will lead to implant failure. However, again, that was in animals. Another animal study by Mayada, and what he found was basically he looked at placing implants into various animals and putting them in hyperocclusion in different heights, different crown heights. So he had 100 microns, 180, up to 250 microns in hyperocclusion. And what he found was if they're slightly in hyperocclusion, it does end up with some bone loss, but it's not that significant. Whereas if you put them into significant hyperocclusion, what he called 250 microns, you can see here by the red arrows, the bone, instead of bone at the implant interface, you get a soft tissue interface. So basically that is a failure. So their studies concluded, again, occlusal overload ended up with bone loss and resultant inflammation. So therefore, if we look at a conclusion on this, on occlusion studies, ideally, if we had meta-analysis systemic review, I could sit here and go through principle after principle and protocol and say, this is how you have to treat every one of these cases. Similar to what we do at the Institute, almost every technique that we teach, there's a protocol. And it's step 1, step 2, step 3, step 4. With occlusion, though, it's different. There's a lot of variables. So in this 5-part series, what I'm going to do is bring out those variables so I can show you, so you can come to the conclusion, yes, in some patients, you do have to splint implants. In other patients, you really don't. So there's a lot of variables that you have to understand with that. If we look at the studies, the human studies, most of them are retrospective out there. They're significant human bias and just way too many uncontrolled variables to say they're even significant. The animal studies are very well controlled. However, we don't know the correlation. Will the animal study actually correlate with what we see in humans? Sometimes they do, sometimes they don't. Bottom line is we need prospective cohort studies, but that's basically unethical, and I don't know if we'll ever have those type of studies in our field. So let's look at another literature issue that we have, and that is called implant failure. Okay, how do we define failure? And what is failure? If we look at failure, there are 2 terms associated with implant failure: survival and success when we look at the studies. So when we look at the studies, a lot of them will use success, a lot of them will use survival. There's a big difference. So if you hear people say that I have 100% success or this study is 98%, it's never that high. Okay. The problem is there is no congruent, generalized process on how to define if it is a failure or not. So let's talk about survival. You might have a study from manufacturer S that says they have a 98% success. But if you look into the study, if you delve into the materials and methods, you'll find that they're using what is called survival. That means the implant's in the mouth. It can be in any condition or patient satisfaction, meaning that this X-ray on the left, this implant in the posterior, in the fourth molar position, is basically, it is not a failure. Number two, the one that they put in to hold up the cantilever is not a failure. The one that is sitting in the sinus is not a failure. The second one sitting in the sinus is not a failure. And the cover screw there also. If we look at the second from the left, all three of these implants are not failures. They're surviving. There is a prosthesis. They're in the mouth, so they're surviving. Or this one, what we call a sleeper. Yeah, the implant's in the mouth, that is not a failure. So when we look at success, on the other hand, that is more specific and that's more difficult. And that means the implant prosthesis is in the mouth and it's functional with patient satisfaction. And that comes into a huge problem. When we look at patient satisfaction, well, we can tell this implant is a failure, okay? It's still in the mouth, though. This implant's outside the mouth. It's in two pieces, but we could fix it and put it back in, so we could make that not a failure. This one, the implants and the prosthesis came out. That's basically a failure. But if you use those other implants, then maybe you could hold on to the prosthesis. So there's a lot of questions on survival or success. The problem that we have moving forward in dentistry, which I think is a huge, huge problem. I see it all the time in medical legal arena, is we knew back in the early days, in the 80s and 90s, we knew that this was a failure. We looked at it and said, okay, we have a failure. The implant's in the mouth, but you can't put a prosthesis on it. And we judged our failure by if the implant integrated or not. We know that one on the left did not integrate. And we could put any type of prosthesis in, and the patient would be happy because all they wanted was a crown there. Aesthetics really wasn't that big of a deal. Even function wasn't that big of a deal, as long as we could get something in there. Now, presently, patients demand and expect not only should the tooth look like the other teeth, the soft tissue should be exactly. So the hard and soft tissue drape need to be exact. And it's very subjective. So this patient, this implant on number 9, maybe this patient doesn't like something about it. So that would be not a success, would be a failure. So aesthetic failures is a huge problem that we're going to have to contend with in the future because of the subjectivity of it. That's the first problem that we have in occlusion. So the literature really is not behind us. We don't have that to come up with those conclusions. Secondly, you have to understand that teeth and implants are different. There are a lot of differences between teeth and implants that you have to take into consideration. First of all, a tooth has mechanoreceptors, an implant doesn't. So there is proprioception. What is proprioception? Basically, it's a negative feedback loop to the brain saying that, okay, I feel that. So that tooth has feeling and you understand it. Now, you might hear a term, it's a newer term called osteoperception. And basically, this is a similar term to proprioception, but it's used for implants. It's actually never been proven. It's just been thought that this is a possibility where you do get tactile sensation. And the thought is that implants can perceive the position, pressure, things like that through nerve fibers in the TMJ, in the muscles, and in the cutaneous areas of the oral cavity. Again, people talk about that, but the studies that do show talk about perception certainly do not substantiate that. So we do have issues. We know that a tooth has a periodontal ligament, an implant does not. So what does that mean? Well, we know that if we put a force on a tooth, we know that this periodontal ligament that surrounds the tooth, which is approximately 0.2 millimeters on average, is going to compress. And we know that that will act as a shock absorber. We also know that if we have an implant and we put that same amount of force on, because the implant interface is bone, it is not soft tissue, it is elastic fibers, so it will not in any of the force, that we have to treat this implant a lot different than this tooth because of the periodontal ligament. So the force distribution is different. With that being said, if we look at tactile perception, meaning the threshold that implants can actually be perceived, here are just two studies. One is almost 9 times higher. Another is 50 times higher. Implants, the threshold is that much higher than natural teeth. That's a significant problem. There's a very good study that evaluated teeth versus teeth. And it shows that if you have natural teeth against natural teeth, and you put in a filling and you have a prematurity of 20 microns, most patients can perceive that and say, hey, doc, that feels high. Whereas if you have a tooth and an implant, that same patient, it's almost a little bit more than double the perception needed or the size of the prematurity. If you have implant versus implant, it's 3 times that of teeth versus teeth. And then if you have an overdenture versus natural teeth, it's the worst. So what does this mean? We don't have the perception on implants that we do have on teeth. And then if we look at mastication efficiency, this is a great study that took hazelnuts and asked 3 different groups: natural teeth, patients who have crowns on their teeth, and then implant prostheses. And they said, put that hazelnut between your centrals and bite it into 2 perfectly even pieces. Well, if we look at it, the natural teeth people, the group did great. They're pretty good. The full coverage restorations, not that great. The implants were horrible, and you can see it's all over the place. They're biting and chewing strokes. So the mastication efficiency just isn't there. So the bottom line is with implants, you have decreased coordination with that. If you look at mastication adaptability, what does that mean? Well, when you have natural dentition and you bite things such as, in this study, gummy bears, as the biting force, as the bolus gets smaller, as the material gets smaller in the mouth, the biting force decreases. Okay, this is a natural occurrence, and it's part of that proprioception feedback loop. If you have an implant, it shows minimal adaptation. So what does that mean? If we're chewing that food the same amount of cycles, instead of decreasing the biting force, we still have an increased biting force as we did in the beginning with an implant. That means that we're putting implants through more force. There's no adaptation because that increased force. Now we're putting more force on the prosthesis, the implants, and the bone at that crestal area that can lead to bone loss. Also, people want to generalize, okay, how do we build this occlusion? And basically, the bottom line is if you have a single implant, multiple implants with natural dentition, you don't change the patient's natural dentition occlusion to accommodate an implant or a couple implants. You modify the single implants or the multiple implants to coincide with the patient's dentition, unless they have an occlusal disharmony where you're going to do full mouth rehabilitation. However, on the other hand, if the patient's edentulous and you're putting full arch implants in, now you have to start at the beginning, and it is prosthesis dependent. If it's a full arch fixed against full arch fixed, now we're looking at mutually protected. If it is an RP4 overdenture, meaning an overdenture that is completely implant supported, we want mutually protected occlusion. However, if we have an overdenture that is soft tissue supported, primarily only secondarily by the implants, now because our soft tissue takes all the force, we need it more of a bilateral balance. So you have to differentiate that. And the last one is the effects of parafunction on implants versus teeth. If you look at the studies, I have multiple ones here. Bruxism, every year, the survival rate or the success rate will decrease. That's well documented. Here's a study that shows bruxers will have 2 times greater failure than non-bruxers. Here's a study that looks at prosthetic complications, higher failure rate, higher technical and biological complications. If you look at this study, at 10 years, you're looking at over 1/3 of those have some type of mechanical complication. Here's a hybrid prosthesis. At 10 years, you're looking at 90% complications. Screw loosening, even though it's far less now, some studies are up to 45%. So all of these are force-related issues. In implants, we're seeing more and more implants fracturing, which we never did in the past. And because of that, we have to look at the forces, and the forces are usually occlusal related. So with that being said, there are a lot of controversies, and that will lead us into the next subject. There's a lot of people out there that disagree on why implants actually fail. There's a school of thought that basically says the occlusion is why you get implant failure, you're late. Let me define early and late failure. Early failure is prior to prosthetic rehabilitation. Late means the prosthesis is on, and depending on, it doesn't matter how long the prosthesis is on, that led to occlusal related bone loss and failure of the implant and the prosthesis. Whereas our school of thought says, no, occlusion has nothing to do with it. It's all biological. It's bacterial. That leads to bone loss and failure. Our thought on it is they're both right. It is occlusion. Definitely occlusion can cause that because we've seen that. Okay, over 35 years of clinical experience, I've seen that. But when you start to lose bone, then you get the biological component to it. And that's why it can be mixed. And that's something you have to take into consideration because when you do lose bone loss, say on this lower x-ray, that might be force related at the beginning, but once you get those threads exposed, unless you graft that or eradicate it, you're going to continue to get bone loss from peri-implant disease from that. But occlusal loading comes from a lot. We cause a lot of this because of where we put the implant, how we make the prosthesis, and it's all these non-ideal principles that are used. So if we look at occlusal schemes, the one problem that we do know that happens is when you have natural teeth and you put an implant or multiple implants in and then try to change someone's whole occlusal scheme because of those implants, that will be problematic and you don't want to do that. Whereas when there's no natural teeth, now we have to develop our own occlusal scheme. However, it is dependent on the implants, which you have to take into consideration. When we look at contacts, occlusal contacts, there's 2 types. One is static. Okay, we know patient bites down. We want MIP to equal CR, or if not, we want freedom in centric. However, there's also dynamic contacts where we have excursive contacts, and that has to be different. So we want cuspid disclusion similar to natural teeth when we have fixed implants or fixed teeth opposing it. However, when we have a overdenture, when we have a soft tissue borne prosthesis, we want a balanced. So it can't be a one scheme for all types of implants. That doesn't work. And we know that doesn't work. So the bottom line is that there's a lot of different occlusal principles out there that we have to implement into all these different types of prostheses. The one thing we do know is, bottom line, we have to decrease our occlusal load and minimize it because of the studies I showed of the difference between implants and teeth and the morbidity that we know that happens post-operatively if we do have an occlusal overload. So I believe the pioneer, the father of these principles is Carl Misch. Carl Misch and Martha Bedez in the 90s, they came up with a protocol called implant-protected occlusion. And now, even though we have modified and added some to this list, this is still their basic work. Martha Bedez was an engineer. Carl Misch was the pioneer in implantology. Together, they came up with this, and it makes a lot of sense. The basis of this means you're going to develop an occlusion that's going to protect the implant and the bone surrounding the implant. So there's some principles, and I don't have much time, so I'm going to have to go through this rather fast. But these principles will be resurrected in the next 4 webinars. I don't have a lot of time to go into each one significantly, but I'm just going to touch on. First one is your occlusal forces ideal should be on an axial direction on the long axis of the implant. Why is that? That's a compressive force. When you get an angled force like right here, that's a shear force. Bone is weakest in shear. Because it is weakest in shear, that will lead to bone loss. And we know that because we get the bone loss around the crest of the ridge. That's where the force is concentrated, and that's why you get the cupping in the bone loss after the implants are in for some time. We want to narrow the occlusal table. If you have a molar here, a natural molar, which has an 11 to 12 millimeter diameter, and we have a 5 millimeter or 4 millimeter implant, how can we have the same occlusal table? We need to narrow the occlusal table buccolingually. So how do we do that? As you can see in that photograph on the right, we narrow it buccolingually. So we bring in the cusp tips. By doing that, this study showed it decreases, but if you decrease the occlusal table by 30%, it reduces the force by 48%. We do that on the maxilla, on the lingual, because of aesthetics, and for lip support, we can just reduce the lingual. On the mandible, we can reduce the facial and concentrate those contacts. We want to minimize our cantilever length. You've heard this before. If you look at with these prostheses that look like ski boots, okay, doesn't make a lot of sense. Would we ever, this one in blue, would we ever take a maxillary molar, take 2 of the 3 roots off, and then cantilever anterior and posterior? Never. But we do on implants because we think they're superhuman, but they're not. We have enough of these cases showing where occlusal force has destroyed the implant and broken the implant and or the prosthesis. We know enough from fixed prostheses now that the AP spread has a lot to do with it, but the occlusal force, also the opposing occlusion. So depending on that dictates how far we cantilever. On this particular case, look at green. Look at these cusp tips. They're huge. That patient's biting down. These are shear forces, and that's why you see all this bone loss around the crestal area. We want to reduce the cusp angle in the height. Why is that? If you decrease the cusp inclination by 10 degrees, it'll decrease the loading by 30%. Here's a study that looked at increased cusp height results in bone loss. It's more significant when there's poor quality of bone. And that is an in vitro study, and it does make sense. If we want to reduce the crown implant ratio, we want a 1-to-2 crown implant ratio. We don't want a 2-to-1, because now that becomes a vertical cantilever. And there's a ton of in vitro studies, computer studies, that show the amount of force to not only the screws, the bone, the abutment, and the resultant complications that can result from that. If we look at full arch prostheses, we're going to talk about anterior guidance. A lot of people make these very, very large slides in anterior guidance, meaning when you come in the protrusive, they want the incisal edge at a height. So what they do is they have a very deep anterior guidance. We want the most shallow anterior guidance we can to disclude those posterior teeth. We don't want this force that's a shear force going on those anterior implants. We want long contact areas, meaning we don't want these little point contacts. Not only do these point contacts make it difficult for you to put the prosthesis in, but it makes it difficult because it's going to open up. You're going to get mesial migration, and then you'll get an open contact. So what do? We like to make guide planes and make a long contact area. We always want to adjust opposing cusps if we have to. So if we have any super eruption around the opposing dentition, we want to adjust that. We don't want that plunging cusp beating into our prosthesis and our implant. Look at this X-ray here. Look at the bone loss on this implant crown, which has a huge plunging cusp in. This one's flat, and there's no bone loss. So that just tells you that the occlusal contacts have a huge component to this. You don't just get back from the lab and say, okay, I'm putting it in. You want to centralize where these contacts are. Here's an in vitro study that showed if you put the force on one of the cusps instead of on the central groove over the long axis, it results in a lot more force. So you can see here in the green, this is all destructive force, and that destroys the bone. So what do? We contour the opposing cusp. We make sure that we have point contacts in the central fossa. We don't want marginal ridge, because marginal ridge, now that's a cantilever. And so you want to stay in this green area, at worst in the yellow area, and not just take what the lab gives you and say, okay, I'm putting that in. We're going to talk a lot about occlusal timing. That will be the next part 2 of this. We're going to talk about how a tooth, when you bite down on it, it has a primary and a secondary movement. Basically, the periodontal ligament compresses, then you bottom out on the bone, whereas the implant does not have that primary periodontal ligament. It's only one force, and that is directly proportional to the elasticity of the actual bone. So we're going to go through an occlusal protocol called timing, where we'll show you how, if you have a single implant or multiple implants, how the patient, in very light bite, there shouldn't be any movement or any force on that implant. When you do put a heavy force, then the contact comes, but it's a very light contact. And we use different types of articulating paper, usually a very thin, like shim stock type of material, to time that occlusion. If we don't do that, then our implant's going to be in infraocclusion, basically in light contact. And what will end up happening is you will end up really putting too much force on it. So we'll show how to time those contacts and how to do that at the next session. Also, in the anterior, you have to remember that the maxillary anterior teeth, they have more horizontal movement than any of the posterior teeth. So in that protrusive movement, you have to make sure that you're free of contact. What does that mean? When the patient bites lightly or maybe a heavy bite, they might not touch, but when they clench, then it might hit. So you have to make sure that you adjust that accordingly. And then we'll talk a lot about what is called mutually protected occlusion. This is occlusion for any type of fixed prosthesis where the anterior teeth protect the posterior teeth by discluding them. The posterior teeth incentric prevent any touching of the anterior. And we'll talk a little bit about group function, where a lot of people still use group function. However, the studies are not good. Group function involves more of the muscle activity. And here's an EMG study. It shows 2/3 of the temporalis masseter muscles do not contract if there is no posterior contact. So when the patient goes into an excursive movement, if you don't contact those, it's going to be a lot less. With group function, here's a study, over 50% of porcelain prosthesis is fractured, only 16% in mutually protected. So we'll talk more about that, but ideally we want mutually protected occlusion. And lastly, I know we're running out of time. I apologize for that, but you always have to think about occlusal guards, especially in patients with hyper function, parafunction, especially patients who are implant against implant. I showed you where the patients don't know how to decrease their biting force. They don't have that feedback loop to their brain. Their dexterity is not as great with natural teeth. So occlusal guards are significant. I'll show you how to make those. Basically, we want a centric occlusal guard, very similar to the type of prosthesis. So with that being said, I went through about an hour and a half of material in about 40 minutes. So let me give you a take-home message on this. First of all, the research studies on occlusal overload and bone loss, it's extremely controversial, but from experience, we know that that does happen. There are biomechanical differences between the teeth and the implants. You cannot treat the same. That's why we can't use natural teeth occlusal principles solely in implantology. We know that implants and prostheses have high mechanical complications, and we know that's force related. So our goal is to minimize the force. How do we do that? Occlusal overload minimizing. That is through principles called implant-protected occlusion. So we'll talk about these throughout the next 4 webinars, but I just want to give you the groundwork. So today we gave you the groundwork. Next session, we'll talk about the single and multiple. Then the third, we'll talk about full arch prostheses, followed by removable. And then the last is I'm going to summarize maxillomandibular relations, how to reestablish vertical, when you should, when you shouldn't, and some of the problems that we see in these immediate load cases because of maxillomandibular relation issues. If you want any more information on this, Dr. Park put together a very nice informational booklet. It's actually four articles that I wrote on implant occlusion, and that's through Glidewell. If you want more in depth, I've written multiple chapters in any of our textbooks will be on occlusion. So with that being said, I am at 1 o'clock and I made it.
You made it. Fantastic job. I've got some questions for you, though. And by the way, that was a great introduction to the topic, and I know that everyone will be looking forward to the next 4, right? 4 more lectures.
Yes.
On this topic. Excellent. So here's a question that will probably bring in a lot of issues, and if you want to delay it to another lecture, let me know. But the question is, if a patient's missing 4 lower anterior teeth and there's enough space for individual implants, would you do the individual implants, or would you connect them with a bridge?
So we have 4 lower incisors missing. Is that the question?
Well, it says lower anterior teeth, but let's say they're incisors.
Okay, so first of all, the one thing that you don't want to do, and this is a common problem, is where you put 4 implants in, and whether they're splinted or whether they're individual really doesn't matter. The reason you don't want to do that is the space. The spacing between those incisors, the implants, there's not enough. We know that we need at least 3 millimeters between each implant. We know that a lower central incisor, mesial distally, is 5 millimeters. The lateral incisor, 5.5. So if we put the smallest implant in, which is 3, and we have 3 millimeters between each implant, right there you're at 9, and then you're 2 millimeters away from a tooth, you're 11. It doesn't work. So the bottom line, how do you do it? Have to do a fixed bridge prosthesis. You put 2 implants in the embrasure area between 23 and 24, 25 and 26. That keeps them away from the cuspids. You come out with a screw retained prosthesis. So you have your 3 millimeters between the implants, and you don't end up destroying the cuspids or causing a peri-implantitis.
Randy, when you put implants in the embrasure area, as you described, isn't that a little hard to get really nice aesthetics?
Well, no, because what you do in the lower anterior, number one, the aesthetics really isn't an issue because most patients don't say that or see it. But if you put them lingually inclined into the cingulum, you can develop an intaglio surface, that ridge area, you can make it almost perfect. And if you look in either of the textbooks, I have a step-by-step protocol on that. But if you look in the complication book, I'll show you multiple complications on putting 4 implants in and what ends up happening.
Got it.
Yes.
Got it. Okay. What about connecting implants to teeth? Some general comments on that?
Yeah. So I am going to talk about that in a future webinar, but let's talk about it right. Let me give you the bottom line is in our career, Neil, you and I, we've been doing this for 35 years. You know, it's gone back and forth 5 times. Sometimes you do, sometimes you don't. The literature says this, says that. Right now, most of the literature is pointing towards you can do that. However, you want to rigidly do it. You never want to use a non-rigid connector. So basically, you want to select it. If you have to, you select a tooth that does not have endodontic treatment in it, does not periodontally involved. It has to be a good tooth, usually one with no restorations in it.
Got it. Got it. Okay, a couple announcements. So Dr. Resnik mentioned this article compilation, which is a really nice. It's almost a mini textbook on occlusion. If you send your mailing address to Nicole, okay, we will mail a copy out to you. Okay, so send us your information. We can mail this for you, or if you come to one of our programs, we'll have one for you there. So that takes care of that. And then I had a question here. Are you doing the prosthetic course this year, Randy?
Yes, we just came up. My schedule is so crazy. It is either in September or October. If you look on the website, that should be up. I believe we just signed the contracts for that. So the prosthetic boot camp will be done this year, definitely. Yes, I do it. I did it twice last year, once this year.
Got it. Got it. Let's see. All right. We have a doctor that says there's good research that patients prefer anterior guidance with removable prosthesis versus group function, as you mentioned. And he even tells us that this seems to work well in New York.
Okay.
I don't know if it works in the other 49 states, but comments on that?
Yeah, when I would say let's push that question to part 4. At the 4th session, I'll talk about soft tissue occlusion, and that is denture occlusion. Anytime when a patient bites down and the soft tissues take the force, mainly on the primary stress-bearing areas, such as the palate and the maxilla, the buccal shelf and the mandible. Every study from, if you remember Geisy or Payne, any of those old prosthodontists, every study for the last 100 years has showed that a balanced occlusion is better for soft tissue related. However, there is a caveat to that, Neil, is a lot of people make overdentures that are implant supported. And that's why I said you have to differentiate between an RP5 and an RP4. An RP5, definitely you want bilateral bounce. RP4, definitely you want anterior guidance. So
Right.
it depends. So if you have a 2 implant overdenture on the mandible where the patient is biting down and the buccal shelf is taking the force, you better have balanced occlusion. Okay. If you try the anterior guidance, you're going to flip that denture right out, the maxilla and the mandible. However, if you have 5 implants and you have a bar overdenture on the mandible, you want anterior guidance because
So implant supported, you basically treat it like a fixed.
exactly. So we
Okay.
treat, even though an RP4 is removable, it's actually a fixed prosthesis because it's not getting any soft tissue support, right? So, whereas an RP5 is a denture that just gets secondary support from an implant. But we'll go through that at session or part 4.
Yeah, the way I used to explain it was the 2 implants will keep the denture from pouring out of your mouth, right? But
Yeah,
it's not going to support it. Yeah,
it's going
that's
to
great.
teeter totter on you. Yeah.
So Nicole has posted her email
You are.
in the chat, and but we need your physical address, right? We're going to mail this to you. We can't send it
My
through
email
the
is
internet.
already.
Okay. All right.
Sorry,
Interesting
Nicole,
question here.
about that.
Yeah.
Can full mouth implants cause difficulty chewing tougher foods like steak? I guess it compared to what? Compared to what they had before, right?
Yes. In fact, Neil, you've heard me say this 100 times, and you worked with Brandmark for many years. What was their pamphlet that they used to give out in the 80s showed what? A patient eating an apple, right? And I still use that today. In my opinion, you should never tell a patient that they can eat any particular food. The reason is those studies I just showed you, you lose the dexterity. You don't have a proprioception. The patients, when they lose their teeth, they lose all their vertical, they lose their centric, they lose, and the muscles atrophy. So the coordination isn't there. So what I tell patients is it's an adapt. You have to adapt to it. Some people do, some people don't. So if the patient comes in and says, I want implants because I can't eat a salad anymore, I tell them, well, it's a good possibility you're still not going to be able to eat a salad because of the dexterity issue.
Right. And you'll be able to eat an apple, but you might need a knife.
Yes.
There you go.
Or a blender.
Now here's an interesting question. For isolated, let's call that single tooth implants, how often should occlusion be checked? And I think this doctor might be referring to the fact that there's this ankylosis issue, and sometimes that the level of occlusion changes.
Actually, it's a very good question. And I talk about this actually at our complications course. I have a whole section on it this week that you should check it almost every time. There's a lot of doctors that I do the implants, they do the prosthesis. I have the patient back every year, and I'm going to say that almost every time I'm adjusting it a little bit. And you have to let the patient know that a lot of times it does have to be adjusted. Usually, it's very minor. It's usually not a large discrepancy, but teeth do move and the implant doesn't, and it can cause problems, especially if you get super eruption or auto rotation of the opposing cusp.
Very good. Thank you so much. Another great presentation, Dr. Randolph Resnik, and we appreciate it very much. And Nicole, when is Dr. Resnik's next presentation scheduled? The next in this year?
April 5th.
April 5th. Okay, good. And we'll have lots of great presentations. In the meantime, in fact, next week, we've got Kathy Bassett. She's going to talk about local anesthesia, specifically in the mandible. She's a great speaker. And thanks, everyone, for joining us today. Thanks to our panel, and especially thanks to Dr. Randy Resnik of the Resnik Implant Institute for his fantastic presentation. We appreciate it. We appreciate all of you. And thanks so much. And we'll see you next week. Take care. Bye-bye.
Okay. Thank you.
Thanks, Randy.
Thank you.